Hello, welcome to Wellness and Wisdom with Dr. Nadu Tuakli, the podcast dedicated to empowering women over 40 to age gracefully, competently, and beautifully. I'm Dr. Nadu Tuakli, a family doctor, preventive medicine specialist, author, teacher, mother, and expert in hormone replacement, anti-aging, and longevity. With decades of experience as a physician and as a woman embracing every stage of life, I'm here to share practical advice, expert insights, and inspiring stories to help you thrive in happiness, health, and appearance. Together with my guests, we'll explore topics that matter most to you, from navigating perimenopause and optimizing your health to redefining success in retirement and beyond. Let's celebrate the aging process with vitality and purpose, because your best years are still ahead. Subscribe now to add more life to your years and step into the best version of yourself. Welcome to Wellness and Wisdom with me, Dr. Nadu Tuakli, where we explore the many facets of living well, from health and happiness to aging with confidence. If you've ever wondered where your desire went, or if intimacy has to mean intercourse, you're in the right place. This episode will challenge what you thought you knew and give you the tools to reignite your passion on your terms. Today, we're diving into a topic that so many women think about, but rarely discuss openly: low libido. Where did it go? Can we get it back? In women, a persistent lack of interest in sex, especially if it causes distress, is clinically known as hypoactive sexual desire disorder, HSDD. But what does that really mean? In simple terms, it's when you feel little or no interest in sex, don't initiate intimacy, and may not even respond to erotic cues. Does this sound familiar? How common is this issue? What causes it? And how do we fix it? Joining me today is the brilliant Dr. Susan Kellogg Spadt, a leading expert in sexual medicine and women's health. She has spent decades helping women reclaim their sexual confidence, and today she's here to help us break the silence and get some real answers. So let's jump right in. Welcome to the podcast, Susan.
Thank you. I'm thrilled to be here.
So why is sexual health important?
Well, sexual health to my mind, is as important as oxygen for breathing and as exercise for the body and blood flow. It's a part of our very essence of who we are as women, and certainly who men are as men. And certainly every gender has a interest, or did have an interest in sexual health. And it's not just the mechanics of sex that makes one healthy. It's the mindset of sex that also makes a person very healthy. It contributes to a feeling of youngness and vitality and just energy overall.
We like the youngness and vitality and the energy.
Yes, exactly.
So what is the prevalence of sexual disorders, and do they increase with age?
So sexual disorders overall, with any kind of disorder or self-described disorder in sex that causes distress, about 12% of all women. This is across the lifespan. But certainly the highest occurrence of sexual dysfunction, or again, problems with sex, is in that 44 to 64-year-old woman at midlife, approaching midlife, going through midlife. And that's certainly for a number of reasons, but not only hormones. There's a lot of other things going on in that woman's life, but certainly hormones or lack thereof can be highly problematic and very much a cause of many of the complaints that I hear.
So it's multifactorial, basically. Mm-hmm. However, 12% to me sounds kind of low.
Well, that's evidence-based. That's evidence-based data. One of the things that the particular study, that was one of the largest studies ever done looking at sexual dysfunction for women, they did not include sexual pain in their data collection. And so had they done that, we would be looking at least at 16%, if not 18% of women.
So Susan, is intercourse really all it's cracked up to be? Or is there more to intimacy than we've been led to believe?
Well, there's a whole lot more to intimacy than intercourse. And I'm not sure that, when I talk to a patient, I was just talking to someone today and I said, can you tell me when the last time you were sexually active? And she said, I don't know, 7 years ago or something like that. And she, previous to this, she had just said that she was, happily married with her partner and et cetera, et cetera. And I said, can you tell me a little bit more about that? Is that the last time that you had intercourse? And she said, yes. And I said, is that the last time you had any type of sexual play? And she goes, oh, no, that was just last night. So you see, we really have the vernacular issue, I think, across the world where sex is equated to intercourse, and specifically sex is equated to penis in vagina intercourse. And there's so many other ways to express oneself sexually. And if we get pigeonholed, if we allow ourselves to get pigeonholed in that fashion, we're really missing out on a lot of sexual pleasure, particularly when things like illness and separation and bodies changing and not working like they used to. We can't just say, oh, well, it's over now. For instance, let's talk for a minute. Let's say that you define dinner as steak. And if you didn't have any accessibility to steak, you just didn't eat. Sometimes that's what happens when the inability to have intercourse shows up. A woman has pain, a man has erectile dysfunction for a number of reasons, but intercourse gets taken off the table. If couples say, well, it was really nice, it was a nice life, but it's over now, we're not going to be doing that anymore. It is equated to just not eating because you can't have steak. There's a lot of other things on the menu, and there's a lot of other things on the sexual menu as well.
Yeah, and with guys, for example, who have had prostate cancer or surgery and different things, they may not be able to function the way they used to, and yet the couple still wants to have some intimacy.
Absolutely.
And a lot of people would like some help with that.
And the incidence of erectile dysfunction in men is so high. It's about 50% of men in their 50s and 60s. So we really have to kind of, again, broaden our scope of what is sex.
Right. And that's important because women need to know it's not just us. So a lot of older women just feel like, well, it's my fault. Like you said, 50% of men with erectile dysfunction is way higher than 12% of women with sexual dysfunction. Yep. So it's all about the partnership. And even if it's not male-female partnership, it's still about the partnership.
Yeah.
So let's define libido and desire. What is libido really? And what are the biggest myths surrounding it?
Well, libido is really more the kind of an everyday term, if you will. I think you did an expert job defining desire as low desire as hypoactive sexual desire disorder. And some of the key principles of that, when we look at it for a woman who says, I don't have any libido, sometimes women are saying they don't have libido when they can't have an orgasm, but their desire is very high. So that is not that. Libido really, in its most clear essence, is that desire, that motivation to either initiate sexual play and or respond to sexual play, and or the presence of sexual fantasies and thoughts, spontaneous thoughts in and out of our life, whether we act on them or not. And so when it's that feeling of being dead inside, like I don't think about sex, I don't want sex, I'm blank when I see a love story in a movie, I just no response at all. So that's truly low libido. What people just don't feel like that they can respond at all.
And is there a difference between spontaneous and responsive desire?
Yeah, absolutely. Spontaneous desire, as its name implies, is when one feels, if one is exposed to a series of sexual cues, like a good movie or a hot person, or just lots of sexual cues out there in life, or a fantasy that they're reading about in their love story book. And when they respond to that, they might feel physical responsiveness, like they might feel their vagina becoming moist and some swelling and some tingling. They might also feel like they start to have more fantasies like, gee, that would be nice for me. Those are all responding to sexual cues. And so that's more of a spontaneous. So let's talk about responsive desire. Responsive desire, again, is not really maybe feeling very sexual coming home. I just came home from a very long day at work today, so sex is not really the first thing on my mind, except with you, of course, when on the podcast. But it's when in a series of everything else, feeling safe and feeling happy and feeling okay. If I was exposed to a sexual scenario, I could think, oh, well, I wouldn't have thought of that myself, but sure, I'll respond to that. I can do that. Sure. Again, I feel safe. I feel happy. I feel healthy. I can do this. Yeah. So that's responsive desire. And many, many women their whole life have more responsive desire than spontaneous desire. And that is absolutely positively normal. But when you don't respond to anything, you don't think about it, that's really a problem. And the last piece of it, as you so expertly pointed out, is distress. The woman has to feel distress about the situation. So let's talk about just quickly one more scenario. Let's say that I say to you, you're here for a low desire. Can you tell me how that impacts your life? And they may say, oh, well, it's fine for me. I'm good. I could go the rest of my life never having any sexual play at all, ever. I'm good. I got this. I'm fine. You see the lack of distress there until they say, however, my partner says that he or she is going to leave and or take on a lover and or this isn't funny for them. That's the distress. There's that distress I'm looking for to cause, because if nobody's distressed about this at all, we don't do it just to do it because the neighbors are doing it, So, yeah.
Many women assume that something is wrong with them when their desire fades. But is this necessarily the case? How do aging, menopause, hormonal shifts affect sexual desire?
First of all, there's no fault really to be assigned for lack of desire. But I think that when women undergo things like menopause, and frankly, when men experience changes in their testosterone levels, so I'm going to say this is across the genders, when people experience changes in their baseline hormonal milieu of their body, they may find that they miss things that were stimulated by said hormones, like spontaneous sexual thoughts, vaginal lubrication, in a case of a man, spontaneous erections in the morning, maybe reactive erections when he sees a good, a beautiful woman or something on TV. Same for the woman. She might feel really excited by things. And when that goes away, it doesn't make sense in the beginning. It's like, wait a minute. I'm in this loving relationship, or I just started dating this wonderful person, and I should feel those tingly feelings, those feelings of wanting to be held and frankly wanting to get naked with someone. And I don't feel them anymore. I'm just like I said, I'm good. I don't have that desire anymore. Again, for most people, that's pretty distressing because they want to know what happened. One more thing is you can have also great hormonal input, but a very bad home milieu or sexual milieu from the psychological and the behavioral space. If she is not feeling safe, if she's not feeling heard, if she's not feeling reciprocated, that will kill libido right there.
So obviously stress, sleep, and lifestyle do play a role in either generating libido or suppressing it or...
Yeah, what a great point. Yeah, I mean, if people are really stressed out, they can't quiet the noise for whatever is stressing them out. If it's grief, particularly, that's very much an anti-sexual kind of a feeling. It is not an anti-cuddle kind of a feeling. People want to be held sometimes when they're grieving. If we can umbrella that in sexual intimacy, we can. It doesn't have to involve anybody touching genitals or having any genitals touched at all. We really broaden our scope of what is sex, what is intimacy, that feeling of connectedness that brings about pleasure, but it doesn't have to be orgasmic pleasure. It can be any kind of pleasure. When sleep is an issue, which it often is when women are having hot flushes and they're up all night going to the restroom, then sometimes what we look at is sex is competing with sleep. Like, even if your desire is there, but it's 10:30 at night. I want to be asleep by 10:45. I don't know if we can pull this off in 15 minutes, So then the distraction begins. It's like, I really want this over with. I want to rush and be finished. Sex should never be in a place where it has to compete with sleep.
Is there an expiration date on libido?
What a great question. No, there really isn't. And there's also not a hopelessness to this space we're talking about. So if people say, am I never, ever going to feel sexually interested again? And is it over for me? The answer is no, no, and no, and no. If you've ever met an 82-year-old or 84-year-old that just met a new person at assisted living, you will know that to be absolutely true. They say things like, we feel like kids again. I'm acting like a teenager again. And this is not necessarily a woman who's on hormones. I'll be quite honest with you. So sexual interest is about that excitement, that interest, that what I said at the beginning, what makes you feel alive and energetic and young again. And so it doesn't have to be over, but it does. Having said, it does require work. It requires the kind of mindset that I am not going to retire from this aspect of my life. even if I've retired from my job. I'm going to keep it going on. I'm going to keep my body healthy, keep the nutrition up, the exercise up, and also keep my sexual interests going. One of the myths about sexual interest is that it's this thing from the outside that like comes to us. And when we lose it, it's just out there. And we don't have any responsibility for keeping it, finding it, nurturing it. It's a thing that happens to us, like the flu. Well, it's not that. Maybe with spontaneous desire, when you feel like, oh my gosh, I'd like to be sexual tonight, out of nowhere. But the truth is, we can talk ourselves in and out of anything. There's a saying that says we choose happiness in life. We choose it. It doesn't just happen. Well, I would say one more thing, and that is we choose sexual wellness for our lives. We choose that. And that could mean just being sexual with yourself. It doesn't mean that we even have to have a partner, to be honest with you.
So we've agreed that intercourse is somewhat overrated.
Yes.
Society places such an emphasis on intercourse itself. How do you guide women who feel pressured to have a normal sex life, but really, like you said, don't have the desire? I'm good.
I think it's really important for if they're partnered, if the women are partnered, to really talk about it with their partner and say, I'm just not feeling a tremendous amount of desire. But that, again, I'd like to say that women are responsible for that too. So if they say, if their partner says, well, babe, can you see somebody about that? Or should we talk to somebody as a couple about that? And they're like, no, it's gone. I have a friend who says, and I quote, that ship has sailed. End of quote. Yeah. So I think that it's important. Communication is hugely important. As a practitioner, one of the things I ask patients is, how is intimacy on holiday when you're on vacation? Because maybe the stressor of daily life is the problem. Maybe that's really what we're looking at. When they're feeling very carefree and they're in a beach setting or something, do they feel more cuddly? Do they flirt a little bit more? It doesn't mean they have to have intercourse, remember, but it means, do they feel that connection again? And if they don't, maybe the place to start is not by forcing the issue of sex, but forcing or adopting the issue of, let's find interest in one another as human beings before interest in another as sexual humans.
So more emotional connection.
Mm-hmm. Mm-hmm.
So we talked a little bit about vaginal pain and vaginal dryness. And obviously, if sex isn't fun, people aren't going to be like running towards it like a light. Can you tell us a few of the other things that you cover when you take care of people's sexual health, particularly in women over 40?
When we look at women over 40, without question, the number one complaint, you would think it is low desire, but the truth is it's pain. That's the number one complaint. And that could be as a result of a surgical procedure. It could be simply as a result of dryness that's gone to the extreme after menopause. They even feel the dryness when they're working out at the gym or something. It's not just in relation to sex. Their vagina just feels very, very chafed, very dry, very uncomfortable. They may be more inclined to have infections like yeast infections or bacterial infections, particularly inclined to have urinary tract infections in the peri and postmenopausal women. So when they start to see that part of their body as instead of an erotic zone, but as a potentially problematic zone, they start to separate out from that part of their body and being active with it. So I always tell people when they come in and they have pain and low libido, I say, well, let's get the pain under control first, so that you can really trust that part of your body again. And then we'll start working on your libido, because you're afraid. You're afraid it's going to hurt. You're afraid your skin is going to rip or tear. You're afraid you're going to get a urinary tract infection the minute that you start to play. So we have to work on that first.
In addition to this, I would assume that the relationship dynamics and communication are also a huge factor.
Yeah. In vaginal pain and sexual pain.
Yes, and decreased sexual activity as you get older.
Yeah.
For example, if you've been with the same partner for 35 years, it might not be as stimulating.
Absolutely. I ask patients also, what are you doing to make sex fun and creative again? And what do you do together when you laugh together? What's going on when you're laughing together? Or do you laugh together? Sometimes a very telling notion is that they don't laugh together anymore. All communication is about the kids or the grandkids or the mortgage or the garbage or whatever's going on.
Non-sexy stuff.
Really non-sexy stuff. And again, laughing and just having a great time, that's very sexy. And so maybe finding some fun. And, the old adage is, do you have a date night? It's really not an old wives' tale. It's an old doctor's tale. I'll tell you that, because it's really important to have date times. It doesn't have to involve spending a lot of money. It could be a walk in the park. It could be watching Netflix or whatever, but doing it together in a spirit of let's play together. In fact, when I talk about sex, I talk about love play or sex play, because it should be playful. Let's face it, most peri and postmenopausal women are not procreating and having a baby. And so if the other piece of that coin, it is just pure unadulterated pleasure. And it doesn't have to be orgasmic pleasure. If that's what they want, absolutely fine. But if it isn't, if they want the pleasure of being held and feeling that lovely feeling when you're being held by a significant other, then that is sex right there.
So what are some of the medical and non-medical strategies to revive libido? We've talked about some of them, right. But when you look at men, they seem to have all kinds of things available for their libido. What do women have available?
So we'll start with some medical things and then we'll do non-medical, if that's all right. So let's start with one of the most important things for sexual play is comfort. So we'll start with pain, I think, even though we're not going to do it a lot, but people need to be comfortable, physically comfortable. So right. There are certainly local estrogen products and local testosterone products. Some of them are compounded, which means they're made by someone other than your regular pharmacist on the corner. They're handmade for women. And if for anybody that I take care of that has a true vulvar pain syndrome, they cannot tolerate things like propylene glycol and methylparaben, which are the additives in many of the over-the-counter products, but also on the shelf at the local pharmacy. Those are preservatives. If patients have pain with almost anything they place, even soap down there, then we need to really look at taking specialized estrogen and testosterone products that are not systemic. Please understand they're local to address the local issues. And we're talking things like breast cancer survivors. We're talking about women who've stopped menstruating and women who have just slowed down in their menstruation. Sometimes you don't have to be completely menopausal to feel that the vulva is starting to feel dry and thin and not responsive. And so we kind of front load that. Let's get you comfy. The other thing is, after women haven't used the vagina or had an expansion in the vagina for any reason, for any length of time, the muscles inside the vagina, which are called the pelvic floor muscles, we're both sitting on ours right now, they actually become foreshortened, not necessarily strong. That's a misnomer, is that short equals strong. They are weak, but they're foreshortened. So they physically cannot expand to accommodate penetration and play, or even a masturbatory play with a dilator or vibrator. It doesn't fit because the muscles are so tight. It's called pelvic floor dysfunction. It is very, very, very common in women who have not been sexually active. It's also very common in people like elite athletes who really overtrain their bodies, for their athletic endeavor. But sometimes the pelvic floor becomes very, very tight as a result of that training. Other people that have tight pelvic floors, chronically constipated women, chronically overactive bladder women, and then sometimes pelvic floor dysfunction can occur after the area has had any kind of incising. So post-surgically, post-baby, definitely another time. So if it's more than dryness, if it's the pain is just searing, if you're on local estrogen and there's still something really wrong, it may be the second part of this puzzle of pain, which is the pelvic floor muscles. So probably a really good idea to have that evaluated. There are specific physical therapists known as pelvic floor muscle physical therapists. For our case, usually it's a female working on a female, but for men can also have pelvic floor dysfunction, and they are also have physical therapists that specialize in men as well. I think that everybody knows about that until I meet another patient and she's like, I've never even heard of this before.
Never heard of it.
So
yeah.
It's really important to put that into the mix. So when we talk about muscles, since we're on the topic of muscles, we talked about local estrogen and systemic estrogen for dryness. For muscles, we use muscle relaxants oftentimes, and we also inject muscles sometimes. If you had a sore muscle right here, I might give you an injection to help that muscle relax, or I might give you an oral muscle relaxant. So we use oral intravaginal muscle relaxants in the form of suppository, oral muscle relaxants, and then injectable muscle relaxants go by the name of botulinum toxin A or Botox. Another name for that is Dysport. We do inject pelvic floor muscles to help them relax and help the work of those physical therapists to rehab the muscles so that the patient can accommodate play. It's just an amazing, amazing journey for them.
When they get Botox injections, they last 4 to 6 months in other places. Is that the case with the pelvic muscle problems?
Yeah, sometimes it's a little closer to 3, depending on how severe the problem was. But I'd say 3-4 months is on the downside, and at the top side, 6, even 8 months for people. And then they often will have to go again. But one thing that's different than Botox here is that when Botox is placed in the pelvic floor, remember, we were talking about that same patient is going to go to physical therapy, and those therapists are going to rehab the muscles so that when the Botox wears off, it won't wear off with such dramatic effects. Hopefully, the muscles will be elongated, the person's core will be strong, their floor will be strong and relaxed. And so when the Botox wears off, many, many people don't need it a second time. And if they do, they don't need it a third or fourth time.
So they don't have to show up 3 times a year for pelvic injections.
Well, some do, but most don't. Let's put it that way.
Oh.
So we talked about those kind of things. There's, I think, probably the burning desire for people want to hear what we use in sexual medicine for low libido or low desire. Let's talk about FDA approved drugs for perimenopausal women. So if they're not completely postmenopausal, there are 2 FDA approved drugs for low desire in perimenopausal women. One is called libanserin. It goes by the trade name Addyi, and it is a pill that one takes every day for at least 8 weeks to see if it's going to work. It has a 60% responder, 40% non-responder rate, so that about 60% of women who take it feel a definite increase in their desire, and about 40% they want it so bad, but it doesn't work for them. It doesn't mean they stop it because of side effects, because there aren't very many, to be honest with you, but they stop it because it's not working. And right in the package insert, this is brilliant, right in the package insert, it says to contact your provider after 8 weeks of continuous use to let them know about the efficacy. And if it really hasn't worked for you, just, this is not something we try for 3 years at a pop. We try it for 8 weeks, 10 weeks. And that makes women feel so calm that they're going to see if it works. And if not, they're not going to take it. They feel safe. It feels safer than like, oh, here, you're on this now for the rest of your life. They might want to take it for the rest of their life, but they don't have to if it doesn't work for them. That is taken every day. It is a non-episodic intervention, which means you don't take it just before you want to play. You take it every day so that overall the libido, the baseline level of libido starts to rise. The side effect profile on that is mild sedation, particularly when it's mixed with a lot of alcohol. So people can have a wine or 2 with it. That's okay, but they shouldn't drink to excess. I always tell patients, if you're going to a wedding and you're really going to do it up all night, skip your flibanserin that night because it doesn't mix with a lot of alcohol. They'd get too sedated. It does have a mild sedation as a side effect, which people love, because another wonderful thing, also to your point, is that sleep is an issue in the perimenopause and menopause, is that people just cannot either get to sleep or stay asleep. And because this has a mild sedating effect, it really does add to the quality of sleep. So 2 for 1 there, more libido and more sleep. So that's libanserin. Another FDA approved product for low desire is called Vyleesi, or melanocortin agonist. This is a injectable. You've heard of an EpiPen before. It's like an EpiPen, and it's injected right into the thigh of a woman or buttocks or wherever she wants to put it. My patients put them in their thigh. And this is an episodic intervention. It's used when you want to play. So it's placed in the body. About 45 minutes to an hour later, a woman starts to feel spontaneous desire in most cases, if it's going to work. And if it does, then that's fantastic. If it doesn't work, it's again about a 60% responder, 40% non-responder. So it doesn't work for everybody. Nothing I'm going to talk about today works for everybody, but certainly it's worth a try for many people. If people ask me all the time, how painful is that injection? Well, if you think about an EpiPen, people do EpiPens with very little pain. And actually, when the studies quantified the pain, it was 0.5 on a 0 to 10 scale. So 0.5 was the level of pain. So it's not you're not bleeding and band-aiding and going crazy because you have this battle wound from an injection.
So it's like Viagra. You use it.
Yep. You use it before
just
you want to play. Yep.
And is there a different dose for different people, or is it one dose for everyone?
No, it's one size fits all right now. And it does have a rather troublesome side effect, and that is nausea. So not everybody gets equally nauseated. And many people say, oh, listen, if I can have desire, I can have a little upset tummy. That's okay. It's not usually vomiting, by the way. It's just nausea. But for people who are very, very susceptible to nausea and or think that's the worst feeling you could ever have, ever, they're probably not going to do well with that if they do get the nausea side effect, because it can last at least an hour, if not more.
How about the person can reduce the dose so that they don't have
the
as much
EpiPen is
nausea?
preloaded.
The pen is preloaded,
Yep.
and there's no way to sort of
not to my knowledge, no.
Play with it. Huh?
No. So, maybe someday, because I mean these are all out within the last 5-6 years. So when a drug is really widely accepted and there's a call from the community to alter it in some way, like I really would like a smaller dose or something like that, you never know. But it takes a lot of drug money to do those kind of things, to create a new product. So off-label drugs mean that the FDA has not approved a given drug for a given population. So I know you've heard of males who take testosterone, right? They take it. They have underarm roll-on. They've got injectables. They have all different options, 26 options to be exact, in terms of their sexual enhancement products. And that includes Viagra and stuff like that. But testosterone is one of them. And it is FDA approved for men with low testosterone. There is some consideration that women with low desire have low testosterone, and their blood work often will say absolutely they have very low testosterone. It doesn't always mean, like with the other two things I talked about, I said 60% responder, 40% non-responder. It doesn't mean that even if a person's T is for testosterone, T is low, and they're supplemented with T and their T comes up, that they will automatically have spontaneous desire. And so it's just one piece of the puzzle, but it certainly is worth looking at for some women. And so we do a trial, very much like with the other two drugs, about 3 months on supplemental T. It's a one that we use is a T gel, a testosterone gel, transdermal, goes into the bloodstream. Another option is T pellets, which are implanted under the skin. There's T injections. There's all different types of implements there that people can use testosterone. It should be medically supervised when one is having testosterone supplementation. And again, if it doesn't work in a reasonable amount of time, like 3 or 6 months, give it up. It's not that, I'll just take more and more and eventually I'll become a 13-year-old boy and that'll eventually do it. Like that's not the goal. The goal is to see if is this the missing piece of libido that will bring tremendous enhancement to a woman, or is it not? And so when people are really confused, if it doesn't work, I, for one, just won't keep prescribing it over and over and over and taking the dose up and up and up. It's not really good medicine. Medicine is to look at a need, address the need, and then reassess once the need is being met. So anyway, testosterone side effects, if given in reasonable doses, very easy to tolerate. Given in pseudo high doses and or in women who are super sensitive to low doses, they could have a very fine downy hair growth on the face or on the nipples, on the belly. They could have more acne. This thing I see most is they have pimples, not like a whole face full, but a pimple here and there like they did in high school. And they might have acne on their back as well. Most doctors and clinicians do not give so much testosterone as to lower the voice of the person taking it, but that is a documented side effect for high doses of T, and it should be discussed with the patient.
If your voice drops, you're taking too much.
Way too much, yeah. Or if it's not fine downy hair, but it's full on body hair everywhere, that's probably too high. So a lot of people feel more energy when they're on T. Some people channel that energy into aggression. They don't mean to, but they get kind of snappy. And so that's probably not, that's not a good idea. I had a woman actually just came in today and she said, I stopped taking that. Yeah, it worked for sex, but I just became like, I was wired and I was aggressive. So, and it was not a very high dose, but that was her body responded to testosterone. So the coolest thing about working with women and the coolest thing about doing sexual medicine is the individualized approach to each patient, and it's certainly not one size fits all. Absolutely not.
Do any of these things make orgasm stronger
Hmm.
or come on quicker?
All of them.
Because I know some women complain that it takes a lot of work to have an orgasm, and then it's not as strong,
When it
fulfilling
happens.
as
Yeah.
they would like.
Yeah. So all the three things I just talked about, I mean, they might be a little extreme to go to a systemic drug like that if orgasm is the only problem. It's certainly often libido and orgasm are a little match set. They come in the same package to women, and they're like, I have no desire and I can't have an orgasm, or if I do, it's so little, it's not even worth it. But for women who just have orgasm problems, then they often will use something a little bit less intense than the three drugs I just talked about. They will use things like Viagra or sildenafil off label. It is off label for women, by the way. Or they'll work with there's many supplements over the counter that actually are vasoactive. That means vessel enhancing blood flow to clitoris, labia, vagina, etc. The other issue that people sometimes use is vasodilating creams on the clitoral hood or
Mhm.
prepuce, or they'll use local testosterone therapy. Let me be clear about this. When I talk about what I just said, that's systemic testosterone for libido. When I talk about testosterone just for the
Just applying to
vestibule
the area.
right. So local is just for the area. It doesn't do a lot of dumping into the bloodstream. It doesn't raise blood levels, but it really works where it's meant to work, which is on the genitals. So that's another way to address orgasm disorder. Certainly using vibrators is a great way to address orgasm disorders for people who have never used a vibrator their whole life. They say things like, well, I've never had to. Well, they might not know what they're missing because
Surprise.
it's really a very, very effective way for many women to have fulfilling, quick, lovely orgasms. So
I know that a lot of the compounding pharmacies actually make what we call the scream cream.
mhm.
And that usually has, the arginine and some of the other vasodilators that you're
Yep.
talking about.
Yeah.
So we just call it the scream cream for short.
Yeah.
And you use it right before intercourse. It does orgasm.
Yeah.
But of course, in order to do that, you do have to have started with libido. Because if you don't have any desire, just applying the scream cream isn't going to make you want to have sex. But when
Right.
you do
No
have the
increase
sex,
in blood flow is going to work on the head to make you feel
getting the
desire,
brain.
unless your orgasms are so overpowering that causes a secondary spike in libido, which I've seen that too.
What are CBD suppositories used for?
Yeah. A couple of things actually. CBD, and that is the part of the hemp plant that is the non-hallucinogenic part for anybody who's listening and doesn't really
It doesn't
understand
make you
that
high.
piece of it. Huh?
It doesn't
No,
make you
it doesn't
high.
make you high. They should come. CBD suppositories are made by many of the dispensaries, and they're also available online sometimes. I personally like to know what the dispensary, where they get their product, how they take out the terpenes, which is the hallucinogenic part of it, what percent is left behind. Can they quantify that? It should be less than 0.3% if you're in an area of the states that doesn't have legalized marijuana. What they basically do is they do a couple things. One is they often cause relaxation, and many of the CBD suppositories have magnesium placed in with the CBD. So they relax the pelvic floor, relax the patient, let them relax. And then the other thing it does is if you're relaxing the mind, you might be more open to just kind of feeling less distracted, let's put it that way, during the sexual play part, and more playful, to be more playful. Again, you're not high, you're simply relaxed if the CBD is working. And people use CBD suppositories for sleep sometimes. They don't want to take it in their mouth for whatever reason. They put it in their vagina or in their rectum and they go on off to sleep. So I'm a very big believer in CBD suppositories. There's no hangover effect. There's very, very, very few side effects. And you can work with dosing, to your point, because they're made in a wax base. Every suppository is. So you can take a knife and cut it in half if you need to and have half the dose, or put in two suppositories if they're not doing anything, but two works better than one. So I'm a big fan of those.
And how long do they take to work?
About 20 minutes.
Is there an age limit to taking the CBD suppositories?
So, we're really in our infancy in terms of the medical understanding CBD from a medical perspective, but they are generally speaking non-sedating, particularly if, once again, the THC is less than 0.3%. It should say it right on there and on the product. And so if they're not hallucinogenic and they're relaxing and they enhance sleep, then they should pose no problem to falling or things like that for elderly patients. But I always just see how comfortable they are with that. Maybe start with, again, a half or a quarter of one to see how they do.
So, what's the one thing you wish every woman struggling with libido knows or wish that they wouldn't know?
Is that you have a voice in this, you have a say in this. Again, the concept that libido is not just this thing outside of you that comes upon you or leaves you forever. You can choose to have libido. It might not look like that, it might look differently, but if you could say, I feel loving today, I feel playful today, I feel sensual today, I feel like being hugged today, to really expand the mind and look at libido for sexual play in the biggest, broadest sense of the word, not I feel horny for intercourse. That's a very narrow way to look at the experience of sexuality in the peri and postmenopausal space. That's number one. Number two, if you are in a dyadic relationship with another person, whether it's a marriage relationship, a dating relationship, a casual relationship, then it is incumbent upon you as a person experiencing this to have a dialogue with your partner about it, rather than like do avoidance stuff, like go to bed at 8 o'clock, hoping they don't show up till 10.
I've got a headache.
Yeah. Like avoidant behavior just goes so far, and it really makes the other person usually feel pretty devalued, to be honest with you, because they don't always understand what's happening. So just to sit down and have a dialogue about my body's changing. Caveat, my feelings about you are not changing, but my body's
That's
changing.
important,
And I would
yeah.
like you to help me with that, or to, come on this journey with me, type of thing. You would do that if you're having palpitations in the middle of the night, you'd say, something's going on, babe. What's going, something's bothering me. So I think
Right.
it's really important to talk about it that way. And also to remember the fact that this is a dyadic relationship. And when traditional marriages take place, we say in front of friends, family, in some cases in front of God, I forsake all others, I choose you. Well, you're asking your partner to forsake all others as well. And so it's at least to try to be involved in some way. It doesn't mean you have to play act and act like somebody you're not, but it also means try to approach the bench, if you will, or the bed, if you will, and just try to do what you can. I mean, you're usually not going to, if you have pain, you're going to hurt yourself if you try to have intercourse. But if you don't do things that you know aren't going to hurt you, it's the event, to be quite frank with you, is between 7 and 20 minutes. It is not a 3-hour marathon. And so if you could, from a sense of goodwill, enter that arena for 7 minutes or 20 minutes, then it's very likely your partner will enter the other arena, maybe whatever it is that you really like, travel or art shows or something like that, enter that arena that they're not inclined to do as a show of goodwill to you. And sometimes it is when the goodwill is flowing that magically libido does show up again. So that's the truth.
So, where can listeners find you and learn more about this topic?
I do not have a podcast right now, although I'm on lots of podcasts through the week, but they can find me in my clinic, which is the Center for Pelvic Medicine. It's outside of Philadelphia in a place called Bryn Mawr, Pennsylvania. And we see women who have, of all ages actually, that have complaints or concerns about sexual pain, sexual desire, arousal, orgasm, and any other kind of sexual behavior, including like if they have a derm problem of the vulva, that falls into sexuality as well. So that's where they could find me.
So, are there specific resources or communities you recommend for women seeking education and support?
Sure. I'm a very big fan of the Menopause Society. It's one of the things that there's lots of information. They have lots of programs that a woman can listen to online or see who is expert in menopause in her community. So that's one, called the Menopause Society, or TMS. Another one is a group of professionals that belong to a organization called ISWISH. That's a mouthful, isn't it? So it's ISSWSH. That's the International Society for the Study of Women's Sexual Health. Very specific society, but very broad reaching all over the United States and in Europe. It involves women and men who specialize in women's sexual health, and they can be psychologists, physical therapists, doctors, nurse practitioners, midwives. All the disciplines are working together toward optimizing female sexual health. Very lovely website, lots of education and opportunities. So that's ISSWSH. And then one more, AASECT, that is the American Association of Sex Educators, Counselors, and Therapists. Sex therapy is an amazing, amazing adjunct to the work that I do, and as is physical therapy. And so one more then, the PTA, American Physical Therapy Association. Find a provider in your area. There's a website for that to find a pelvic floor therapist. Woo, that's a lot.
Are they readily available? Are there many physical therapists
Well,
that do
in
the
large
pelvic?
metro areas, they're very, very plentiful, and not so much in the rural areas, I would say. But there is a new trend that physical therapists will see you virtually like this, and they'll take you through exercises to help your pelvic floor.
Oh,
And so
okay.
they'll reach out to patients all over the world and help them that way. It's really
So
nice.
you can do it virtually.
Really nice.
That's good in the privacy of your own home.
Yeah, exactly.
Well, Dr. Kellogg Spadt, I really, really appreciate you coming on this evening, taking the time to talk to my listeners about this critical topic of not just libido, but women's sexual health in general.
Mhm.
I would love to have you come back and talk about some of the other things that we haven't had a chance to talk about. But many, many thanks for your time, for your knowledge, for sharing, and being a pioneer in some ways. A lot of women listening, I'm sure, had no idea that sexual health was so involved, so complex, and fixable.
Absolutely, it's
So
fixable. I have to tell the listeners one more time, just don't shut down it. You don't have to. You just don't have to. You just need good help. That's all.
you just need to go for it.
Yep, absolutely.
Okay. So thank you so much for coming in,
My pleasure.
and we'll talk to you again soon.
Okay, thank you.
Sexual health does not have an expiration date, and neither does pleasure. Today, we uncovered why libido shifts, how to nurture intimacy beyond intercourse, and practical ways to rekindle desire at any stage of life. Yes, intercourse may be overrated, but intimacy and sexual health is not all about the act of intercourse, as you heard from our conversation. So if this conversation resonated with you, please share it with a friend, explore the resources we mentioned, and remember, you are not alone on this journey. So I look forward to seeing you again on the next episode of Wellness and Wisdom with Dr. Nadu Tuakli.